The following podcast is part of a certified educational activity titled Navigating Weight and Sleep: Best Practices for Non-Judgmental Weight Management in Obstructive Sleep Apnea Care. Access the entire activity and complete the post-test at peerview.com/UVY860. Downloadable slides and practice aids are also available.
Hi, I'm Jamie Almendos from the Weight Wellness Program at UT Southwestern Medical Center in Dallas, Texas. Our goals for today will be to augment your knowledge of the evidence for approved obstructive sleep apnea treatments and then to equip you with patient-centered strategies to treat OSA in people living with obesity. It goes without saying that obesity is associated with a multitude of different health complications. We traditionally think of things such as cardiometabolic issues like type 2 diabetes and cardiovascular disease, but it's important to emphasize that there are also respiratory and pulmonary challenges for people living with obesity, primarily obstructive sleep apnea, which we're going to be talking about in detail today. To start, I want to highlight the importance of understanding the anatomy and normal airflow that happens, particularly when we're asleep from a breathing perspective. We can see here the airflow through the nasal passages and oropharyngeal passages towards the trachea in a way that supports optimal respiration and oxygenation of the blood. Obstructive sleep apnea is an example of sleep-disordered breathing, and this can be characterized by episodes of partial collapse or hypopnea of the upper airway during sleep, or complete collapse, known as apnea, and you can see this demonstrated in the figures towards the upper part of the slide. This results in intermittent hypoxemia or low oxygen levels in the blood, arousal from sleep, and fragmented non-restorative sleep. So our patients will say that even though they're sleeping, they're not feeling rested in the morning. It's estimated that 936 million adults have mild to severe obstructive sleep apnea worldwide, and that about 34% of men in the United States and about 17% of women have an AHI of 5 events or greater per hour. It's important to understand that there is this bidirectional relationship between obesity and obstructive sleep apnea, where about half of patients with obstructive sleep apnea have obesity, and about 45% of patients with obesity also have obstructive sleep apnea. Risk factors for obstructive sleep apnea include higher BMI, greater waist circumference or high waist to height ratio, older age, male sex, postmenopausal status, a family history, and certain race ethnicity groups. In addition, obesity-related sleep disorders aren't just about sleep apnea. There can be sleep-disordered breathing, primary snoring, insomnia, and restless leg syndrome, amongst others. It's important to acknowledge that obstructive sleep apnea is associated with a variety of different cardiometabolic complications, including worsening of obesity, congestive heart failure, rhythm issues like atrial fibrillation and nocturnal dysrhythmias, cardiovascular events including stroke, cardiometabolic issues including type 2 diabetes, dyslipidemia, high blood pressure, and primary pulmonary hypertension. And it's important to note that obstructive sleep apnea can also lead to reduction in quality of life, increases in cardiovascular risk, and negative impacts on mental health. We're going to focus in a little bit about mechanisms with respect to cardiometabolic challenges for people living with obesity and obstructive sleep apnea. And what I want to highlight on the left is the relationship between excess adiposity in general and risk for obstructive sleep apnea as it pertains to our ability to get oxygen sufficiently through the upper airways and into the lungs for gas exchange. What we see here on the left-hand figure are the associated increases in visceral and abdominal fat in somebody who is at risk for obstructive sleep apnea. And what we can see is that there are a variety of different impacts on the impact of respiration. But in addition, we know that visceral fat and excess adiposity is associated with a variety of different cardiometabolic issues. On the right, what we see is a bidirectional relationship between obstructive sleep apnea and obesity demonstrated here, in addition to the metabolic challenges that people living with excess and dysfunctional adiposity can face, including increases in sympathetic nervous system activity and activation of the renin-angiotensin-aldosterone system, pro-inflammatory markers such as increases in IL-6, TNF-alpha, and CRP, in addition to a variety of different pro-inflammatory cytokines that can be a result of excess body fat that result in a variety of different challenges, including insulin resistance, hyperglycemia, and cardiometabolic risk. And these are the hallmark of the metabolic syndrome. When we look broadly, what I like about this diagram is it shows a bidirectional relationship between increased adiposity or increased fat mass and some of the downstream metabolic effects that are associated with it, such as insulin resistance and hyperglycemia, that also drive the excess adiposity. When we think about sleep apnea, there are weight-dependent impacts that will limit mechanical factors that allow for optimal gas exchange. In addition to this, there are physiologic changes that increase inflammation, lipolysis, and a variety of factors that can worsen cardiometabolic risk. So it's important to understand that while there's this bidirectional relationship, there are many complex factors at play when it comes to the impact that weight can have on sleep apnea, in addition to the pro-inflammatory state that can worsen cardiometabolic risk and outcomes. In addition, this is only one piece of the puzzle as we understand it. And when we look at the important role of sleep as it pertains to cardiometabolic and endocrine regulation, it's important to note that during sleep, there are a variety of different changes that occur that support optimal endocrine and cardiometabolic health, including testosterone cycling. And so when we look here, we can see that it's an important part of sleep regulation to have optimal hormone levels. And it's a common presenting factor, at least in my practice, where men with undiagnosed and untreated obstructive sleep apnea will present for evaluation of low testosterone. And so it's important for us to understand the role this can play, not just in cardiometabolic, but in broader endocrine and other health outcomes. When we look at the recommendations from the American Academy of Sleep Medicine with regards to obstructive sleep apnea treatments, many of these have traditionally focused in on optimizing respiration by using positive airway pressure devices. And these can include continuous positive airway pressure, which is the first line treatment for moderate to severe obstructive sleep apnea. There's bilevel positive airway pressure, which allows for augmented support for people with hypoventilation syndromes. There's automated continuous positive airway pressure that allows for dynamic changes within somebody's pressure support needs throughout the night. And then there's also oromandibular devices, which are more popular with patients who are unable to tolerate or do not like the concept of continuous positive airway pressure machines. I think it's striking, and many of you in clinical practice will know that CPAP adherence can be challenging. And studies and surveys show that non-adherence rates remain around 1 in 3 people. And this can be a challenge for patients who have cardiometabolic issues that are exacerbated by their obstructive sleep apnea, such as hypertension and dysrhythmias, who really need evidence-based treatment. Many of my patients will ask, well, you've diagnosed me with obstructive sleep apnea, and the recommendation is that I use CPAP. Is this going to help me to lose weight? And I think it's important for us to be upfront that the evidence is really mixed when it comes to this. And I think it's important to understand that using CPAP is going to improve cardiometabolic health, but it may not ultimately impact the excess and dysfunctional adiposity that's also contributing to negative cardiometabolic health outcomes. So it's important for us to help our patients to understand what are the challenges for obstructive sleep apnea when we have high BMI, and focus in on how can we treat the underlying cause of the obstructive sleep apnea. When we look at obesity and obesity treatment to prevent progression of obstructive sleep apnea, or really to address this as an upstream challenge, many people who are newly diagnosed with obstructive sleep apnea really don't receive recommendations on how to do this effectively. And I think this is unfortunately a failing of many of our medical systems, where we focus in on the downstream effects of disease rather than focusing in on addressing the underlying physiologic challenges. When we look at people who are in the Veterans Health Administration, only about 10% of people will receive weight management recommendations within about a year of a new sleep apnea diagnosis. And the majority of these will receive recommendations around lifestyle management. And when I say the majority, I mean that of those who received recommendations, 9% received recommendations around lifestyle, only 1.2% around pharmacotherapy, and 0.2% received bariatric surgery. So it's important for us to consider what kind of evidence-based therapies are we providing patients to help to address underlying causes for obstructive sleep apnea, such as their obesity. The ATS clinical practice guidelines for managing weight in patients who have obstructive sleep apnea really emphasize strongly lifestyle interventions and bariatric surgery for treating underlying obesity. What is recommended is that for those who have a BMI of 25 kilograms per meter squared or greater, receive comprehensive lifestyle interventions that include reduced calorie diet and increased physical activity. For those who have a BMI of 27 or greater, consideration for anti-obesity pharmacotherapy, and for those with a BMI of 35 or greater, that bariatric surgery is considered. The general guideline around weight reduction for people who have obstructive sleep apnea is that around 5% weight reduction will improve obstructive sleep apnea and may help to resolve mild obstructive sleep apnea. However, 10 to 15% may reduce obstructive sleep apnea severity by 50% in patients with moderate obstructive sleep apnea. So what we're seeing is that greater magnitudes of weight change will lead to greater improvements in their obstructive sleep apnea. When we look at the landscape of available treatments, lifestyle modification in general will help people to lose up to 10% body weight. But those of us who work in clinical practice know that it's difficult to achieve and maintain clinically meaningful magnitudes of weight loss with lifestyle modification alone, and that the use of pharmacotherapies, which are listed here, can really make this job a lot easier. Pharmacotherapies, including GLP-1 therapies such as semaglutide and tirzepatide, can consistently help patients to lose greater than 10% of their baseline body weight in a way that can help them to avoid procedures such as bariatric surgery, which on average can help people to lose in excess of 20% body weight, but there may be a perception of excess risk when it comes to surgical procedures. So pharmacotherapy has really revolutionized how we approach and treat obesity and its underlying cardiometabolic issues. When we look at the impact of interventions on sleep apnea outcomes, a recent meta-analysis showed that for those who do a diet-only intervention, it led to significant decreases in BMI, and exercise-only programs led to significant decreases in AHI, but no improvements in BMI. And so all that to say is that while lifestyle modification is foundational for health, it may not help people to achieve clinically meaningful reductions in AHI to the point that their sleep apnea is either resolved or they don't need to use continuous positive airway pressure management. Bariatric surgery can be helpful for helping people to lose clinically significant amounts of body weight. And so in the SM-BOSS trial, a 25% reduction in body weight associated with bariatric surgery led to sleep apnea remission in about 45% of participants. And so what we really are highlighting here is how can we help people to lose clinically significant amounts of body weight in order to improve their sleep apnea outcomes. When we look at pharmacotherapies for weight reduction, liraglutide here in this study called the SCALE sleep apnea trial at a dose of 3 milligrams, which is the currently approved dose for treating obesity, showed that there was a weight reduction of about 5.7% at 32 weeks. And when we look at the AHI change in the figure on the right, we can see that this led to reduction in AHI for those who were treated with liraglutide relative to placebo. However, when we look at agents that can help people to achieve a greater magnitude of weight change, such as tirzepatide, and in this study here, what we're showing are for people who were treated for obstructive sleep apnea with tirzepatide who were not currently using positive airway pressure management. And what we can see is an average weight reduction at 52 weeks of about 18% of their body weight. And then what we see is a significant reduction in apnea-hypopnea index of about 27.4 at 52 weeks. And I think it's important to note that beyond reductions in body weight and beyond reductions in AHI, treatment with tirzepatide also decreased hypoxic burden, reduced inflammatory markers like hsCRP, and was associated with improvements in systolic blood pressure. And so there are improvements in patient-reported outcomes and cardiometabolic risk factors beyond improvements in obstructive sleep apnea. In another part of the study where they looked at people who were using positive airway pressure management, again, they saw significant reductions in body weight of about 20% by 52 weeks and reductions in AHI by more than 30 events per hour with this. And I think it's important to highlight that as a result of this, tirzepatide is now approved for treating obstructive sleep apnea in people who are living with obesity because of its impact in these studies. And so what we have now is a pharmacotherapeutic agent which is approved for treating obstructive sleep apnea as an additional option for people living with obstructive sleep apnea. But of course, no medication is without side effects. And what I want to highlight is that there are several for which we should be aware for GLP-1 classes in general. Primarily, gastrointestinal side effects are the most frequently reported, and about 1 in 4 people will report some kind of gastrointestinal side effect, including nausea, diarrhea. Vomiting can be seen in around 18% of people in the SURMOUNT-OSA trial. In addition to some other non-specific GI issues, constipation and others are also noted by some patients. And I think it's important for us to note that incorporating additional lifestyle modification changes, including dietary education, adequate hydration, use of fiber, reducing the amount of fat that we consume, can help to modify some of the risk for experiencing adverse gastrointestinal side effects that can lead to treatment discontinuation. It's important to look at this in a broader picture, that while we focus in on lifestyle interventions, as we discussed earlier, this often does not lead to clinically significant weight loss, which is durable. And it's important for us to incorporate a variety of different treatments across somebody's life course because obesity is a chronic and complex disease. And be that pharmacotherapy or bariatric surgery as part of a chronic care plan that reinforces the use of healthy lifestyle interventions to make sure that our patients achieve not just a weight goal, but their overall health goal, because effective obesity care is about improving health and quality of life, not just BMI. To help, we have some handy practice aids that you can download from the site. And here is one from the American Academy of Family Practice on principles for managing obesity and evidence-based techniques for implementation. It's important for us to know that there are a variety of different factors that we can incorporate into our clinical practice, including identifying our own biases and assumptions, using patient-centered communication, and making sure that we pursue lifelong learning, because weight reduction is complex and obesity science is constantly evolving. In addition, there are different ways in which we can approach this, and these are the 5 S's for sleep management that can be used in clinical practice, where we survey in terms of what's going on, we support the patient's lifestyle and behavioral and other health changes. We use smart shared decision making, we find solutions, and we also signpost to make sure that we provide the right referral pathways to support our patients on this journey. Our key take-home messages from today's activity are that obstructive sleep apnea and obesity are bidirectionally linked, and the consequences of untreated obstructive sleep apnea may worsen hormonal and metabolic dysregulation. Lifestyle-induced weight loss decreases severity of obstructive sleep apnea, but rarely resolves it alone. We should consider obesity medications and evidence-based therapies for treating obesity in people who have obstructive sleep apnea, and that what we really need to do is to individualize treatments to provide patient-centered care for treating underlying obesity in those living with obstructive sleep apnea. That concludes our discussion for today. I hope you found the activity informative in understanding treatment options for obstructive sleep apnea in people with obesity. And I hope you feel more confident about treating obesity to manage OSA. Be sure to download the slides and the accompanying practice aids, and thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/UVY860.